Welcome back to the deep dive. Today we are tackling a big one, a really big one. Chapter 78, the knee and leg.
It's a huge topic.
It is. And if you've ever felt just, completely overwhelmed by the sheer number of ligaments and muscles down there, you are definitely in the right place. We're going to try and distill the essentials on what is, I think, arguably the most complex joint in the body.
I'd agree with that. It's this anatomical marvel that's always in a state of, well, conflict. The knee has to handle these incredible crushing forces just to hold you upright.
Right, the stability part.
Exactly.
Right.
But at the same time, it has to deliver this really precise, rapid movement for walking, for running. And it does all that not with a simple ball and socket, but with a specialized hinge joint that's really three different compartments all working together.
So our mission today is to make sure that by the end of this, you can close your eyes and actually build a mental map of this whole region. We're going to cover the bones, the soft tissues, the nerves, the vessels, and really try to visualize it all without needing a single picture.
Correct. And a good place to start is the basic architecture. You've got two bones in the lower leg, and they're connected by this tough interosseous membrane. The lions share the work. The weight bearing is all on the big medial tibia.
And the fibula.
The fibula is sort of its slender partner. It's there for muscle attachments and, critically, for ankle stability down below, but it's just not built to take that primary compression load.
Okay, so let's unpack that and maybe start at the back of the knee. That diamond-shaped space that seems to be the main highway for everything going down the leg, the popliteal fossa.
Yeah, think of it exactly like that, like a congested highway intersection. It's absolutely essential, but it's also incredibly vulnerable. And knowing its borders helps you figure out what might get hurt.
So what are we looking at?
Well, the diamond shape is formed up top and on the outside by that big prominent biceps femoris muscle.
Okay.
Then superiorly and medially, you've got the semimembranosus and semitendinosus.
Yeah.
And the bottom of the diamond is basically sealed off by the two heads of the gastrocnemius muscle.
Now, this is where that mental map really comes into play. Because inside that tight space, you have the artery, the vein, and two major nerves. And their arrangement is specific.
It's very specific, and the layering is fascinating. The popliteal artery, which is just the continuation of the femoral, is the deepest thing in there. It's running right up against the bone.
Right.
The popliteal vein sits just on top of it, more superficial. But the real surprise is the nerve. The tibial nerve comes right down the middle, but it crosses behind those vessels. So it's actually the most superficial structure in the midline of that fossa.
So if you were to, say, stick a needle straight into the back of your knee in the middle, you'd hit nerve, then vein, then artery.
Precisely. And that closeness to the bone, plus all the dense tissue around it, means the popliteal artery is really at risk. In a bad distal femur fracture, a sharp piece of bone can just tear it.
Or even just swelling in that tight space could compress it.
Absolutely. The fascia won't give.
And the other nerve, the common fibular nerve, it's not in the middle with the others.
No, it kind of skirts the edge of the diamond. It takes a much more lateral, and I'd say more exposed path right alongside the biceps femoris tendon. We'll come back to that one because it becomes really vulnerable just a little bit further down.
Okay, let's pivot from the back to the medial side of the knee. The sources talk about organizing the soft tissues into layers, which sounds like a really useful way to think about it.
It simplifies a really complex area. Think of it in three functional layers. Layer one is the most superficial one. It's mostly the deep fascia that's covering muscles like sartorius, and importantly, the saphenous nerve runs in there.
Okay, layer one is fascia and a nerve. What's layer two?
Layer two is the real workhorse of medial stability. That's the large superficial part of the tibial collateral ligament, or TCL.
Got it. And layer three, being the deepest, must be the joint capsule itself.
Exactly. Layer three is the capsule. But it also includes the deep part of that same TCL. And this is what makes a layer 3 injury so concerning, because that deep part is actually made of little ligaments, the meniscotibial and meniscofemoral ligaments, that pin the medial meniscus to the tibia and femur.
Wait, so if layer 2 is the main stabilizer, does that mean a layer 3 injury is way more serious? Because you're not just tearing a ligament, you're potentially detaching the meniscus.
It absolutely is. A superficial TCL tear is common. But if layer 3 is involved, it points to a much bigger disruption, one that could mess with the meniscus function and lead to some serious instability. And you also have the medial patellofemoral ligament, the MPFL, in there, which is the main thing stopping your kneecap from sliding sideways.
Let's ground all this in the bones themselves, the tibia. Everyone knows it as the shin bone, and for good reason, it feels like it's right under the skin.
It pretty much is. That whole medial surface is subcutaneous. There's almost nothing between skin and bone. And that means a trauma that might just give you a bruise somewhere else could lead to an open fracture or ulcers or even a nasty bone infection like osteomyelitis.
And at the top, you have the condyles.
Right, the big medial and lateral condyles with the intercondylar area between them, and then that big bony bump right on the front, the tibial tuberosity, that's where all the force from your quads gets delivered.
Ah, and that's the spot that gets sore in young athletes, the Osgood-Schlatter thing.
That's the one. It's the attachment for the patellar ligament, and in a growing adolescent, all that pulling can actually cause bits of that growth plate, the epiphysis, to fragment.
Yeah.
A classic cause of knee pain.
And then there's the fibula. Its slender partner sounds almost insignificant.
It's deceivingly important. It doesn't carry much weight, no, but it's a critical attachment point, and it's essential for stabilizing the ankle. But anatomically, its neck is a danger zone.
And that brings us back to the common fibular nerve. You said it was exposed.
This is where it gets really exposed. The nerve wraps right around the posterolateral aspect of the neck of the fibula. It is, without a doubt, the single most common place for a nerve compression injury in the whole lower limb.
From what? A plaster cast?
A tight cast, yeah, or even just squatting for too long. A direct hit. Anything that puts pressure there can damage it and lead to that classic foot drop where you can't lift your foot anymore.
And finally, the patella, the kneecap, the biggest sesamoid bone.
Right, embedded entirely within the quadriceps tendon. It acts like a pulley, increasing the leverage of your quad muscles. The interesting detail is on its back surface, the part that touches the femur. A vertical ridge divides it, and the lateral facet is usually bigger than the medial one.
And why is that?
It helps keep the patella tracking properly, centered in its groove. And there's this tiny little strip on the very edge called the odd facet, which only makes contact when your knee is bent all the way. A neat little adaptation.
Let's move on to the actual connections, the articulations. There's a minor one first, between the tibia and fibula up top.
The superior tibiofibular joint. It's a plain synovial joint, doesn't move much at all. It's just held tight by some small ligaments and, of course, that big interosseous membrane.
Okay, now for the main event. The tibiofemoral joint. The sources are really clear that the surfaces just do not match up. They're incongruent.
And that's the core engineering problem of the knee. You have these round, convex femoral condyles sitting on a relatively flat, slightly sloped tibial plateau. If it was a perfect fit, it would be stable, but you wouldn't get the motion. So to fix this mismatch, the joint relies almost entirely on its soft tissues, chief among them, the menisci.
Describe those for us. They're more than just shock absorbers, right?
Oh, way more sophisticated. They're C-shaped pads of fibrocartilage. The medial one is a semicircle, and it's pretty fixed in place. The lateral one is almost a full circle, 4/5 of a circle, and it's much more mobile. Their main job is to act like custom inserts, deepening the tibial surface to make it fit the femur better.
So they improve the congruence? What about this hoop tension idea?
It's a brilliant piece of engineering. When you put weight on your leg, that downward force gets intercepted by the menisci. Their fibers are arranged circumferentially, so they convert that straight down force into an outward pushing tension, like the hoops on a barrel.
Ah, I see.
This spreads the load over a much wider area on the tibia, preventing all that stress from being focused on one tiny spot.
And a meniscal root tear, then, would completely break that system.
It's devastating. If you tear the meniscus off its anchor point at the root, the hoop tension mechanism is gone. The whole thing is useless. Biomechanically, it's the same as having no meniscus at all. Your contact pressures go through the roof, and the knee just starts to wear out incredibly fast.
Which really highlights how much we need those internal structures, the cruciate ligaments, the cross inside the joint.
The cruciates are immensely strong, very complex, and full of nerve endings. They are inside the capsule, but outside the synovial lining. The ACL, the anterior cruciate ligament, attaches at the front of the tibia and goes up and back to the lateral femoral condyle.
And it's not just one cord, is it?
No, it's more like a fan of fibers, usually described as having 3 bundles. This makes sure that some part of the ligament is always tight, no matter where the knee is in its range of motion.
And the PCL, often called the stronger of the two.
Correct. The posterior cruciate ligament is thicker. It attaches to the back of the tibia and goes up and forward to the medial femoral condyle. It's the main thing stopping the tibia from sliding backwards. And the key thing to get is that the ACL and PCL tighten reciprocally. They work together as dynamic guides for that rolling and sliding motion of the femur.
And to wrap up the joints, just to revisit the kneecap stability.
Statically, it all comes down to the medial patellofemoral ligament, the MPFL. It's the structure that almost always gets torn or stretched when someone dislocates their kneecap laterally. And it's always good to remember the patellar ligament isn't really a ligament. It's the end of the quad tendon, transmitting all that massive force.
Okay, moving from the passive structures to the dynamic ones. The muscles. The sources break the leg down into compartments, which is a huge clinical concept.
It is. The leg is divided by these really tough sheets of fascia into 4 compartments. You have the anterior, or extensor compartment, the lateral, or fibular compartment, and the posterior compartment, which is so big, it's divided into a superficial and a deep group.
And this rigid structure leads to that principle. One compartment, one nerve.
That's the key organizational detail. The deep fibular nerve does the anterior compartment, the superficial fibular nerve does the lateral, and the tibial nerve takes care of the entire posterior compartment, both superficial and deep parts.
Clinically, why is this so dangerous when you get bleeding or swelling?
Because that fascia doesn't stretch at all. So any swelling from trauma or even just overuse can jack up the pressure inside, and you get compartment syndrome. The pressure cuts off blood flow to the muscles and nerves. It's a surgical emergency.
And that's where you get the classic 6Ps.
Exactly. Intense pain that's way out of proportion. Paresthesia, that pins and needles feeling. Pallor, the skin goes pale. Paralysis, the muscles get weak. And then the late signs, pulselessness and poikilothermia, which means it gets cold.
Let's pull out a few key muscles. In that deep posterior group, tibialis posterior sounds like it's the foundation of the foot's arch.
It is the architectural workhorse of the foot. It's the deepest muscle back there, and it's the main muscle that inverts your foot. But its crucial job is dynamically supporting the medial longitudinal arch. If that tendon fails, if it stretches out, you get an acquired flat foot. Simple as that.
And in the superficial group, you have the big calf muscles, the triceps surae. What's the difference between the gastrocnemius and the soleus?
The gastrocnemius is the big, powerful one you see. It crosses 2 joints, the knee and the ankle. It's for dynamic, propulsive movements like running and jumping. The soleus, which is deeper, is the postural muscle. It's working pretty much constantly when you're just standing there making tiny adjustments to keep you stable.
Okay, we've set up this idea of an unstable bony joint that relies on soft tissue. Let's talk about the key muscle that fine-tunes it all, the popliteus.
Popliteus is the key to the locked knee. When your knee is fully straight, it locks into place with something called the screw-home mechanism. To start bending it, to flex it, popliteus has to contract first to unlock the joint by rotating the tibia medially. It's the initiator of flexion.
And that leads us to the actual movement. It's not a simple hinge. It's a combination of rolling and sliding. Why does it have to do both?
Well, think about it. If the big round femur just rolled back on the small flat tibia, it would roll right off the back edge after about 20 or 30 degrees and dislocate.
Okay.
So the sliding motion, which is guided by the cruciate ligaments, keeps the femur centered on the tibia as you go into a deep squat. It's a brilliant solution to keep things stable through the whole range of motion.
And that screw-home mechanism that popliteus has to undo.
That's an automatic, non-voluntary movement. In the last 30 degrees of extension, because of the shape of the femoral condyles, the femur has to rotate medially on the tibia. That twist locks the joint into its most stable, close-packed position. It makes standing much more efficient, requiring less muscle work.
Let's talk supply lines, the arteries and nerves. What's the story with the popliteal artery?
We mentioned its vulnerability in the fossa. It's basically tethered at the top and the bottom, so it doesn't have much slack. This makes it really susceptible to being torn in a traumatic knee dislocation. Eventually, it splits into the anterior and posterior tibial arteries to supply the rest of the leg.
But the sources mentioned a kind of safety net around the joint.
Yes, the genicular anastomosis. It's this incredibly rich network of smaller arteries that connect up all around the knee. It's fed by several branches. Think of it like a detour system. If the main popliteal artery gets blocked, this network can often provide enough collateral flow to keep the lower leg alive.
And on the venous side, the deep veins are a big deal when it comes to disease.
Especially in the soleus muscle. Because it's always contracting a little, it has this huge venous plexus inside it where blood moves quite slowly. This makes it one of the most common places for a deep vein thrombosis, a DVT, to form. And when the valves in the veins fail more generally, you get chronic stasis, blood leaks out, and you get that brand staining on the skin from hemosiderin, which can eventually lead to those nasty venous ulcers.
So to finish, let's just quickly recap the 3 main danger zones for the nerves, the places you have to visualize to protect.
Okay, number 1, the common fibular nerve right at the neck of the fibula. High risk of compression, leading to foot drop.
And number 2?
The tibial nerve. It's vulnerable superficially in the popliteal fossa and also a bit deeper where it passes under a tendinous arch of the soleus muscle,
And the last one?
the saphenous nerve, specifically its infrapatellar branch. It's located exactly where surgeons make their incision for medial knee surgery. It almost always gets cut, leading to numbness below the kneecap and sometimes a painful neuroma.
That was incredibly thorough. So if we boil it all down, the knee's stability seems to come from a partnership between three things: the shape of the bones, which is refined by the menisci, the static tethers, like the cruciate and collateral ligaments, and the dynamic control from the muscles.
That's a perfect summary. And as a final thought, just consider this. When you're just walking, the forces going through your knee joint are 2 to 4 times your body weight.
Wow.
And that huge repetitive load is managed not by being rigid, but by this incredibly sophisticated system of rolling and sliding, guided by tiny ligamentous restraints. It's a true miracle of biomechanical engineering that lets us move the way we do.
An amazing system. We really appreciate you sharing your sources with us for this deep dive into the marvel that is the knee. Keep learning, keep asking questions, and we will catch you on the next one.